Thank you, Senator Cantwell. Last year, IHS made the decision to move funding away from at least 2 New Mexico tribal health facility projects on IHS's list of facilities that need to be replaced. One is in Albuquerque. It's the Albuquerque West facility, a priority for Santa Ana Pueblo, and one serving the Navajo Nation in Gallup, which is one of IHS's largest facilities, serving a large portion of the Navajo Nation. Actions like this depriving the tribes of these funds creates uncertainty and hinders negotiations and planning. Worse, the tribes, the Pueblo and the nation, had no explanation as to why the funds were moved, allowing them no opportunity to resolve any issues and maintain their funding. Last year, I met with the leadership of Santa Ana Pueblo, and they told me the Pueblo had broken ground on a new facility, and it is shovel-ready. I believe funding has been restored there and want to be sure that it will not be removed again. Mr. LaRoche, yes or no, will you commit to prioritizing these projects and using the encouraged 638 authorities where possible?
Definitely all of the facilities that are on our grandfathered list are our priorities, and we do encourage the 638.
And just to be clear, Mr. LaRoche, both those projects are on that list.
Correct.
Appreciate that. Mr. LaRoche, yes or no, will you commit to meaningful consultation with sovereign nations before IHS chooses to move their funds out of their projects?
We do realize that we do need to discuss that with them. I believe within that authority or the funding authority or whatever, we were able to kind of move things around, but we do need to make sure that we contact and work with the tribes whenever something's done like that.
Are you comfortable with committing to meaningful consultation with these sovereign nations if that's a decision that IHS is making?
It will follow the tribal consultation policy.
I appreciate that. Just because when discuss versus meaningful consultation, as we know, two different things. So I very much appreciate that, Mr. LaRoche. Lastly, Secretary Kennedy visited the Navajo Nation last year and specifically mentioned access to water as a priority. But just yesterday, there are signs that remain at the Gallup Indian Medical Center stating that the water in the hospital is not safe for human consumption. So there were letters or there were signs that were up when the Secretary was in New Mexico. He didn't go, but I asked the same question. All of a sudden, those signs were taken down. Well, now there's new signs that are up. And the sign's different, so to the credit of the staff, they didn't put the same signs up if they were reprimanded for saying the water's not drinkable, but now it's a picture. And it says the water is for hand washing only. Now, the little bit that I know about water is when you can't drink it, you're not supposed to wash your hands with it either. It's a hospital. So my question, Mr. LaRoche, is when will IHS restore safe drinking water at the Gallup Indian Medical Center, and what is your plan to do so?
I don't have the details on that. I will need to go back to our Office of Environmental Health and Engineering and check on their plans. For that.
I appreciate it. I'd like to hear back as soon as possible and see if you need authorities, if there whatever is needed to work with my colleagues. If there are any IHS facilities in the country where it's a hospital, they don't have drinking water, I don't think there's going to be disagreement to say, no, they should have clean, safe drinking water. Mr. LaRoche, so I apologize. I said that. I told myself I was not going to say your name incorrectly today, sir. Mr. LaRoche, last week IHS announced it's launching a major hiring push to rebuild and strengthen the IHS workforce. I appreciate that, and this is welcome news, I think, by all of us. My question, though, is how do you plan to implement the hiring push and actually get health providers into facilities? Because I've heard from my constituents that they've been unable to hire staff because they face red tape and background checks that can take 6 to 9 months for some of these positions. Now, I appreciate saying that there's going to be a major push. My question to you is, what are you going to do to address the foundational issues that have held up hiring?
That's a great question. With bringing on over 3,000 people is our goal for this next year. We have brought together our HR team as well as what you had mentioned as the other people who are involved with getting people on board and getting the recruiting and so forth. So we have had a meeting on that to approach it in a comprehensive way so that we can have all the parts of our organization ready for that big hiring.
Is it fair to say, Mr. LaRoche, that 6 to 9 month backlog, that timeline, that will be condensed? They'll look for inefficiencies in there, see what needs to be done to make sure that we're not losing healthcare providers when they're recruited. They say they want to go move there, and then they're told, well, in 9 months, you have a job.
We're definitely working on that to reduce that time.
I appreciate
frame,
that.
definitely.
What I'd be interested, sir, is if you could detail for me, and we could work with the teams, why the background checks are taking so long. So if there's things that we need to do together, that we look at that as well. And then what is the concrete problem that needs to be fixed to speed up the background checks? I'm very interested in that. There were a few providers that were identified for a few small facilities in New Mexico, and they lost them because of the 6 to 9 month delay. And they need a paycheck as well. They need to take care of their families, and they had other opportunities, even though they were ready to move. And so if there's something we could do there, I'd be very interested in working with you.
Thank you.
Yeah, thank you for that. With that, I recognize Senator Cortez Masto.
Thank you. Welcome to the panel members. Thank you very much. I do want to focus most of my questions on S.1055, which is the Indian Health Service Emergency Claims Parity Act. Currently, Indian Health Services beneficiaries are required to notify the Purchased Referred Care, commonly known as PRC, the office within 72 hours of receiving outside care during a medical emergency. Now, the last thing patients should be thinking about during an emergency is having to file the paperwork to make sure their hospital visit is properly covered within the 72 hours of that emergency. So for me, and I think this is why Senator Rounds, I was so pleased that he introduced this legislation and I joined him on it. I think there's an opportunity here to make common sense here, right? So is there this legislation that we introduced, the Emergency Claims Parity Act, it extends the reporting deadline for IHS patients who seek emergency care outside of those IHS facilities from 72 hours to 15 days. 15 days. Now, Deputy Director LaRoche, in your testimony, you indicated concerns over flexibility, noting that S.1055 would limit the Indian Health Services authority to a period of 15 days. Are those concerns? Could you elaborate on the concerns?
I'll say that we do support the 15 days, but if what we're saying is if it is put into law, that if we ever wanted to even extend it longer than the 15 days, go to 21 days or something, that we'd have to come back and go through the federal process here.
Is there, and because for seniors and people with disabilities, they have 30 days.
Correct.
Is there a reason why we shouldn't look at 30 days just for everyone?
We could take that back for consideration.
But right now, you do support the legislation, the 15 days.
Correct.
Your only concern is the flexibility if you want to make it longer.
Longer, correct.
Okay, we might be able to work with that. Thank you. I appreciate that. That's very helpful. Let me ask you this. Yesterday, I introduced a piece of legislation, the Stronger Engagement for Indian Health Needs Act, again with Senator Rounds. This bill would elevate the director of IHS position to an assistant secretary at HHS, granting greater authority over recruitment, retention, and interagency coordination. In fact, Secretary Kennedy, in testimony at his nomination hearing before the Senate's Health, Education, Labor, and Pensions Committee, expressed support for this idea. It's not new. Senator John McCain previously introduced the bill, and it has passed the Senate before. Given the recent introduction on the bill, and I understand you probably need more time to review it and take it back, but I would just appreciate your review and your thoughts on it. Not now, but in the future, at any point in time. Obviously, it's not new legislation, but I think it is important, and I would love your feedback at some point in time. Would you be willing to work with me?
Thank you. Yes.
Great. Thank you. At the end of the day, let me just say this. I think for many of us, particularly those that have Native American communities, tribal communities in our state, we got to do a better job of providing them opportunities for care for Indian health services. I hear it in my state. We're hearing the conversations and the concerns today on these three bills. Can I ask the other panel members, is there anything else that we should be aware of that we haven't addressed today that you would like to make us aware of concerning whether it's the bills that we heard or the concern just in health services in Indian country or Native American, Alaskan country as well?
So I think regarding the bills that you heard today, especially the two PRC bills for us, is IHS looking at their PRC program as a whole, because the $42 million carryover that we had at the Colville Service Unit was, I, as well as our other council and staff were there at the negotiations, were dumbfounded when we heard how much money was there. And it was very disheartening, because when you have people dying daily because they're not getting the health care that they need, and then you find out that IHS has been hoarding $42 million that could have sent them to get the care they needed, it's heartbreaking and gut-wrenching. So I think if that is something that can be looked into with the PRC program, I've worked for the PRC program myself earlier on in my career. I worked with a big part of the problem is the fiscal intermediary not paying the bills as well. We were using New Mexico Blue Cross Blue Shield, I believe, at the time as who we were going.
Not paying the bills, they were denying the claims, or just not?
They just were not paying them.
Denying everything. There's nothing that you could do that you've seen that
they weren't paying them, and that's why they were getting sent to collection some of the time, was because the fiscal intermediary wasn't taken care of for whatever reason. And our staff at the local level tried to work with them, like, what can we do? What do you need? What documentation can we submit to get those bills paid? But it's just such a cumbersome process. So I think to help that process for others, we have our own FI now because we're contracting, but to help the other tribes that are still with IHS and their PRC, that would be something that I would recommend looking into.
Okay. Ms. Ross, anything else?
Thank you for the question. I would just add that the support of self-determination that tribal organizations have within them, the ability to manage their own programs and funds successfully, innovatively, and with quality. So just the support of expansion of self-determination. Thank you.
And thank you. And then, Deputy Director, anything else that you would like to respond to that you heard today that we need to be aware of as well?
Again, supportive of the bills, and really looking forward to working with the tribe, Southcentral Foundation, and the tribes. And I will say our PRC program, we've been going through a lot of improvement efforts over the past couple of years to do exactly what was brought up here with working with the fiscal intermediary and trying to remedy those. So we're still working on that. So continuous improvement.
Thank you. Thank you all for being here.
Thank you, Senator. I just have a couple quick follow-ups here. Mr. LaRoche, you note in your testimony that IHS has seen what we're referring to as bad actors in the PRC space when it comes to private providers not following Section 222. The provision prohibiting them from seeking payment from a patient, and you also know that this legislation doesn't provide any mechanism for consequences. Has IHS taken any steps to end agreements with or otherwise discourage these bad actors?
Definitely where the bad actors have been identified, we have been working directly with them to go through and make sure that it's not just that they don't understand the process or they're looking for certain things that they're not receiving, to be able to put those or get paid by other the other payers that may be involved and things like that. So we are working on that. So it always starts with working together with them and finding out what that problem is. But if there is anybody that's been egregious, we usually don't continue with them. But one of the challenges is sometimes those providers may be the only ones within a reasonable area. And then that ends up, we have to look for people kind of outside of a closer area.
That's not a good outcome. You keep somebody that you know has got a bad track record. That's not helping improve the system at all. So Ms. Seymour, it's my understanding that because of what we're seeing with IHS's poor management of the PRC program, you're actually seeing fewer local health providers who are willing to participate in the program. So to your point, Mr. LaRoche, you're saying you might not have anybody in the area, and then because you've got things that are poorly run, you have providers that say, no, I'm not interested in participating, or do you have non-IHS providers that have refused to perhaps schedule appointments with members that have unpaid prior balances from previous PRC claims? I mean, I look at this, and this situation just does not get any better. You're just making it harder to get access to care, even if it's bad with the provider situation.
So from Colville's perspective, we have seen providers who have canceled contracts with us because they haven't gotten paid. We've had patients go to their appointments and not be able to be seen because they don't have a purchase order or they have an outstanding bill that wasn't paid.
So on that last point, so if I'm that person and I have an outstanding balance, if I have a condition that I need to be seen for now, am I flagged because I have this unpaid prior balance? So I go in, I check in for an appointment, and I'm told, sorry, we can't see you for this appointment?
Yeah, basically that's what has happened. And sadly, we've even had people turned away for cancer treatments and oxygen and different things like that because they have outstanding bills.
And so the only alternative for me in that situation would be to say, well, I'll just pay out of pocket?
Yeah, basically some of them, if they have the means, will make a payment at that time so they can be seen. And that's how we end up in this situation is, they should be reimbursed, but IHS won't tell us why, but that they can't. They just keep saying they can't reimburse patients. But some of them, like I said, are elders, or we live in a high poverty area. So most of the people that we provide services to can't afford to take $100 out of their pocket to pay on a medical bill so that they can be seen by their provider that day. So
you last year, so you're not even 6 months into your 638 agreement here. Are you hearing from those who are part of Colville Tribe that the situation is better now? Do they know that they're not going to be turned away at their appointment because of unpaid prior balance with it? I guess I want to know whether or not you have seen improvements because of the direction that you've taken.
We have seen improvements, and some of that has come from patient communication, but it's also came from our staff who are initiating the payments and making sure that the payments are being paid timely. They've worked diligently to make sure that they're establishing contracts with all the providers we use, communicating with the providers so they know the process that they need to follow to make sure that we get payment taken care of. And
are you seeing more providers that are perhaps now interested in?
Yes, we've actually had providers reach out to us to say, hey, we would love to work with you guys who had previously canceled due to IHS non-payment. But now that they're hearing that we have our Colville Tribal Healthcare Authority administering that program, they're more willing to work with us because they trust that they will get paid.
Yeah. But I think this is where you really see self-determination play out in a way that is meaningful, provides for that balance and those true results. And I think just having Ms. Ross from Southcentral Foundation on the panel here today is an example of what you really can do when it comes to tribal health organizations coming together and working to meet the needs of folks where they are, not being as directed or controlled by operations 4,000 miles away. But I think we see very strong examples where not only are we talking about those principles of self-determination, but we're seeing them in action. And, my hope is that those in the Colville Business Council are going to see positive results as you assume this direction. And to you, Mr. LaRoche, I think you've heard some really good examples of the challenges that are being faced. We've talked about this in this committee for a long time, and I'm in a different situation than my colleague in South Dakota, and I'm very proud of what Alaska Natives have come together to develop through our tribal health organizations. In many ways, we're leading the model when it comes to healthcare delivery, and that's exciting. But to know that so many in Indian country are struggling with a system that is clearly not working for them, and in many ways is just punitive on many different levels. When you are choosing to not access care because you're fearful that you don't know how this whole reimbursement process is going to work, or if it's going to be reimbursed, or if you're going to get sent to the debt collector, it's not a place that we should be. So I'm really thankful that the committee is going to engage in these legislative initiatives, and look forward to working with colleagues to help advance them, as well as with the department. And I think I'm reading body language here, and you have not given me serious frowns or no. You're kind of acknowledging some of the deficiencies, the real deficiencies within the department, and an acknowledgement that we need to address them. So look forward to doing that. And with that, the committee stands adjourned. We'll be taking testimony or questions for the record for 2 weeks after this. Thank you.